Hello everybody, I'm back. Dr. K.K. Agarwal, 7 p.m. shows, Med Talks with Dr. K.K. Agarwal. And today we have a special edition, 50th edition in a row every day. Basic purpose to create awareness about all aspects of prevention in this pandemic time. Let's have the headlines of the day. Russia releases first batch of its Sputnik 5 COVID-19 vaccine into civil circulation. So the vaccine is there in civil circulation. Cost of RT-PCR reduced to rupees 2,000 Maharashtra. They were earlier thinking to reduce it to 1,500, but I think they now made it from 2,400 to 2,000. WHO Director General says world must be ready for the next pandemic. That means pandemics will keep on occurring. When we were a medical student, we were told pandemics needs to occur every 10 years. E-Sanjeevani, the health ministry's telemedicine platform, records 3 lakh teleconsultation. A good number for a Ministry of Health. India scales a new peak of 5 crore total COVID tests and tests per million on a continuous rise. Let's go to the subject of the day. Understanding blood thinners. Ever since this virus has come in the circulation, ever since Italian reports have come that viruses can precipitate hypercoagulable state. In the past, we have known that inflammatory bowel disease also has a hypercoagulable state. And now this virus has caused a hypercoagulable state. That means if you develop COVID-19 or a coronavirus 19 illness, you are more prone to get hypercoagulable state, but with a difference. The D-dimer is high, but the fibrinogen levels are also high. And these hypercoagulable state may not be responding to simple antiplatelets. To understand about the difference between antiplatelets and anticoagulants, let me call upon Dr. Praveen Chandra. He is the chairman, interventional and structural heart cardiology at Medanta, the MedCity in Gurgaon, a Padma Shri awardee, did the first TAVI in the country, and a well-known person. I don't have to describe once I say that he is a Padma Shri awardee. Rest all becomes immaterial. But before I start, what do you mean by structural heart cardiology?
Yeah, good evening, Dr. KK. First of all, congratulations for the 50th running show, and I'm very impressed with the, with the content and the way you are running the show. So, and I'm sure you are going to touch 100 and many more hundreds. So now coming to the question you have raised about TAVI, and basically the structural heart program is now basically meaning that the structures of the heart, which is the valves, up till now mainly heart disease treatment was treatment of heart attack or prevention of heart attack, where we were giving medicines, admitting patients in ICU, and the valves of the heart were only treated by the surgery. There was no other treatment till the last 10 years back when we started this treatment of structural heart, which means now we can replace the heart valves, we can repair the heart valves, and we can replace or repair even the leaks in the heart by doing interventional treatment, which is non-surgical treatment. And this non-surgical treatment of heart valves is known as structural heart interventions.
So एक ऐसी सिचुएशन जहां पे अभी तक एंजियोग्राफी करके आप हार्ट की ब्लॉकेजेस खोलते थे और अब पूरा वैल्व खोलना तो छोड़ो, वैल्व पूरा बदल देते हैं. And that's what Dr. Praveen Chandra is talking about, a structural heart disease. Coming back to the topic today, that we have a hypercoagulable state. We used to say that every surgery is a hypercoagulable state. Immobilization is a hypercoagulable state. Prolonged immobilization, prolonged journey on a flight is a economy class syndrome, and if you are going for a long journey in a car, also is a hypercoagulable state happens. And now this virus is showing us that the virus itself in the body is a hypercoagulable state. How, number one, why in this hypercoagulable state the antiplatelets are not working the way it should have been working? What is the difference between antiplatelets and a hypercoagulable state?
Okay, that's a very good question. And we have been using antiplatelet, which means that the drugs which control the white cells, which lead to clotting of the blood inside the arteries or inside the body. And then there are red cells, which also control the clotting of the blood inside the body. So there are two mechanisms which run parallel inside the body to control the bleeding. So, for example, if somebody has a cut or an injury, then blood starts coming out. But eventually it will stop on its own. Why? Because body has a natural mechanism of controlling blood loss or controlling any bleeding from any side. And this is known as the natural clotting mechanism. But what happens is sometimes the body loses this control, and then the blood starts coming out or blood starts coagulating, which means that the control is gone. And in this coronavirus infection, what is happening is that the control of blood clotting system in the body is failed. It is a failure of the system, which means that the blood which should circulate inside the body by the white cells and the red cells start clotting inside the body while the patient is not bleeding. So the blood clot has to be controlled, because in the body, if there is any clot anywhere going into the brain, into the heart, into the lungs, it can lead to stroke, which means heart attack, brain attacks, and lung attacks can happen because of this abnormal clotting which is happening in patients, especially these days, which we are talking about in corona infection. And that is mainly led by very serious inflammation or infection, which controls or basically decontrols the clotting mechanism. So to take care of this problem in these patients, to prevent stroke, to prevent lung clotting, to prevent brain clotting, we are giving two types of medications. One for the white cells, which is the platelets, and the other is for the red cells or the clotting mechanism. So for the white cells, it is antiplatelets, which is aspirin or clopidogrel. But this is only half part of the clotting system. The half part of the clotting system is red cells. So for the red cells, we give an injection known as low molecular weight heparin. So in patients who are suffering from coronavirus today, who have developed the signs of inflammation, there we give injection of low molecular weight heparin twice a day till the time the inflammation is there, which is about 10 to 12 days, and then we stop it. So that is how we are preventing the serious complication, because most of the deaths were happening because of formation of clots inside the lungs and formation of clot inside the brain, formation of clot inside the heart.
So जो लोग एंटीप्लेटलेट्स ले रहे हैं आज के डेट में, हार्ट पेशेंट्स, डायबिटिक्स, हाई कोलेस्ट्रॉल, आफ्टर एंजियोप्लास्टी, आफ्टर बाईपास सर्जरी, आज की डेट में तो उन केसेस के अंदर में इफ दे डेवलप कोविड-19, will they be prevented from development of a clot, or they will need extra protection by the red clot?
Okay. So first of all, this is a very good point कि भाई जो पेशेंट्स जिनको हार्ट डिजीज हो रखी है, जिनको एंटी प्लेटलेट ट्रीटमेंट चल रहा है, तो क्या इस एंटी प्लेटलेट से उनको प्रोटेक्शन है कि नहीं? डेफिनेटली है उनको प्रोटेक्शन. They are protected in general, that the chance of having a clot will be lesser. But if they develop an infection also, then they have to take that additional injection of low molecular weight heparin during the period of the corona infection. So very important thing is do not stop. This is advice we are giving to every heart patient who has corona or who doesn't have corona. Please do not stop your medications. Whatever medications you are getting, which is generally including one anti-platelet or blood thinner tablet, they have to continue. उनको कंटिन्यू रखना है, नहीं तो जो उनको प्रोटेक्शन है वो खत्म हो जाएगा. So that
So
must
coming back
continue.
to the newer oral anticoagulants, which are now available, I'm not talking about warfarin or other types of drugs, the newer oral anticoagulants, because when it comes to a home treatment, and those people who are opting for home management, home care management, it may not be easy to take a low molecular weight heparin. Nobody will come and give unless you take it self, unless you learn it to take a self-treatment. Can we give them a newer oral anticoagulation? As up-to-date says, you can give rivaroxaban 10 milligram daily, or dabigatran you can give 110 milligram 2 tablets daily as prophylaxis.
Absolutely. This is, I think, a very important point, because now many countries, many cities, and many doctors are thinking and treating about 30% of the patients at home, or maybe more than 30, maybe 50%. So you are right. How can you give injection to these people? So in these people, the alternative tablet which is available can be given to these patients, and this is very intuitive actually. We do not have any big trials to say yes, that should be given, but in the current situation, this is the best second alternative. And amongst that, as you raised, that the new tablets are so good, you don't have to do any testing to see whether they are effective or not. They are generally effective in 99%. So as you already told, the dosage are advised like 10 milligrams of rivaroxaban, and it should work well in home isolation management.
So, which are the patients I'm talking about? Are we going to take it a high viral load as a consideration for starting prophylaxis? Obesity, blood pressure, high uncontrolled LDL, or uncontrolled blood pressure, heart failure? Should they be on a prophylactic because you are going to be isolated? You are not going to come out of the house. So likely that you are not going to move, you are not going to walk. So it can be a prolonged immobilization. Every patient of isolated in home is type of a prolonged immobilization. So which are the patients where we can start it on day one?
Okay. So those patients who are very mild, like they are positive, but they are not having many symptoms, and they do not have any oxygen desaturation or any signs of inflammation on the blood test, like the ferritin levels, like the D dimer, like the CRP. If that is also not high, then the only treatment they have to take is aspirin alone. That is enough. But those patients where there is signs of pneumonia, which means that the level of infection is high or the level of inflammation is high, their blood tests are not too good. In those patients, they have to be on blood thinning tablets, as you already mentioned, if they are at home. Otherwise, if they are in the hospital, they will be given injection low molecular weight heparin to prevent this problem.
I want to come back to one more subset. There are studies which says that LDL cholesterol is reduced in corona inflammation. We all know low-grade inflammation when the C-reactive protein is between 1 to 3. And we know when the CRP is between 1 to 3, that LDL becomes more sticky and starts getting deposited. So therefore, we said if your LDL is high and CRP is also high, then we need to treat LDL rapidly and aggressively. But if your LDL is high, CRP is normal, you can wait for a lifestyle management for some time. Now, in this condition, CRP is like on a rapid fire. CRP may be 20, 30, 40, 100. And in such cases, when the inflammation is very high in all the arteries, LDL get consumed and you have clots. So these clots also have a reduction in LDL levels in the body. So do you think that if a patient has high LDL, uncontrolled high LDL, and CRP is more than 3, we should start prophylactic newer oral anticoagulations on day one? The day you diagnose this condition, I'm putting a postulation. And the postulation is that high grade inflammation, because if I'm going to wait for the pneumonia to develop, happy hypoxia specifically, coagulation has already started. In this virus, by the time pneumonia comes and the patient has hypoxia, take it for granted, clots have already formed. And if I want to prevent those clots, in a situation where I'm giving a hypothesis, CRP more than 10, C-reactive protein more than 10, which is a sign of high-grade inflammation, C-reactive more than 10, uncontrolled LDL, other risk factors like diabetes, hypertension, MI. Why should I wait for a pneumonia to develop and then start prophylaxis? Why can't I give prophylaxis? Because every day you say that when you're going for an economy walk travel, you take prophylaxis. Why can't I give prophylaxis to them? A, and B, why can't I give them, when you give a atorvastatin stat in an acute MI, in every case of acute heart attack, you give 80 milligram atorvastatin. Why can't I give 80 milligram of atorvastatin whenever I'm starting a low molecular weight heparin or I'm starting a newer oral anticoagulation drug?
So, Dr. KK, I think these are very fantastic postulations and derivations from our previous experiences of treating acute heart attack and acute stroke. Certainly, these are very intuitive. They should be thought of, but unfortunately, we do not have enough, data or any study to show that yes, those patients who received high dose statins or medium dose statins in this subgroup of patients will really benefit or not. But I must say at this time, the information which we have is that all those patients who are hypercholesterolemic, who are on statins, who are on aspirin, please do not stop the statins, which is anti-cholesterol medications, and do not stop any of the tablets. Even ACE inhibitors should not be stopped in these patients because there was a controversy whether ACE inhibitors increase the chance of COVID or not. But now it is very clear that that all has to continue. Please do not stop it.
I want to go further in much more simpler way. Do you think this is the time for us to focus on lipids and control the lipid? Everybody requires a lipid of 80. If somebody has an uncontrolled lipid, the cardiologist should come back and say, this is the time to control your lipid. Because if your lipids are high and if you develop corona, the complication rate may be higher. I'm only talking about an opportunity for people that maintain and control your lipids. It's a time for the lipid to be controlled. Unfortunately, people are not talking about lipids control in this particular pandemic.
I cannot disagree at all with this idea because this is absolutely logical, absolutely perfect way of thinking, and it is absolutely reasonable to do this kind of thing. But as I said, we need to have some more studies to go to do on this, and I think this is a good opportunity as a cardiologist, and maybe you can initiate one of these studies where we put these patients on statins and then see whether the incidence of having any cardiovascular event was minimized in this subgroup of patients or not.
I know of a Bombay task force protocol. So they give as a routine atorvastatin and aspirin to everybody on day one. They are not giving Novak, but they are giving aspirin and statin in everybody in people, I'm say high risk people, those two type of people. So I again want to come back to the high sensitivity CRP, a CRP of between 1 and 3. If you see that this is metabolic syndrome, we see high sensitivity CRP between 1 and 3 is associated with insulin resistance, hyperinsulinemia, diabetes, obesity, hypertension, inflammatory bowel disease, and these are the ones who are getting high risk for this disease. Do you think somehow or other the time has also come for us to talk about that if you have a high, low-grade inflammation, trying to manage it today, that not only control your LDL, but also maintain your high sensitivity CRP to less than 1?
Absolutely. This, information to for the first time of controlling the cholesterol levels and decreasing events in those patients who have higher CRP levels, starting from 1 going to beyond 3, came from the Jupiter study many years back. And that is the time when rosuvastatin was being used in those people who do not have heart disease, who do not have any stroke or any bypass surgery or any acute MI in the past. They were advised to take statins as a primary prevention strategy from the Jupiter trial. So I think you are absolutely reasonable to say that yes, in these patients they need primary prevention. So as a primary prevention measure, statins can be added to aspirin in patients who are suspected or having COVID infection of any severity.
So whatever you want to do, our basic objective is to prevent hypercoagulable state and prevent formation of clot. We'll be back after a short break, and after the break we will talk about the safety of these drugs, and then we will come back to आज के सिनेरियो में बायपास और एंजियोप्लास्टीज कैसे हो रही है.
Okay. Thank you. कैसे एक्सेस करेंगे? डॉक्टर रितु, ये इस पे ना यूट्यूब पे लगा लो.
You are watching Med Talk with Dr. K.K. Agarwal live on Facebook and YouTube. And I have with me Dr. Praveen Chandra, an eminent cardiologist, a Padma awardee who is interacting with us on hypercoagulable state. With the difference, fibrinogen भी बढ़ रहा है और D-dimer भी बढ़ रहा है. नॉर्मली जब D-dimer बढ़ता है तो fibrinogen कम होना चाहिए, लेकिन यहाँ दोनों बढ़ रहे हैं, यानी कि लाइसिस भी हो रही है और साथ में क्लॉट भी बन रहे हैं. So I come back to when we talk about this oral anticoagulation drugs, how risky are they? Because specifically newer anticoagulation drugs, are they risky? Have you seen any risk? Because they are slightly longer duration of action compared to low molecular weight heparin. How safe are they?
Yeah. So Dr. KK, I think a lot of studies have been done for the use of these agents in varying dosages in patients who are having atrial fibrillation. For these patients, the main use of this drug was to prevent clot formation, same usage which we are thinking in COVID patients. So the results from these trials, because that is what we have in this time, showed that the risk of bleeding is not higher compared to other types of anticoagulations. But certainly, there is a very small risk of bleeding, which can happen is from the stomach, from the other parts of the body which are weak. But otherwise, majority it is safe. The safety of these agents have already been proven. They can be taken for a short period of time, for a long period of time, and fortunately, in COVID infections, they have to be taken only for a short period. So the risk of bleeding will be very, very low, I believe.
So I come back now to another treatment of clot, that is paralysis, heart attack, and lung clot. Lung clot, heart attack, and brain clot. तीनों के clot को dissolve करने के लिए we have drugs starting from streptokinase to etilactylase. But now tenecteplase, everybody is talking about heart attack में भी दे सकते हैं, lung attack में भी दे सकते हैं, और brain attack में. So do you think आज के समय में when we have patients with clots all over the body and who are not responding, who are on ventilator, why can't we give a try of tenecteplase? I know tenecteplase trial was going on in Mayo. I don't know what happened to that. Why are we not trying tenecteplase in such cases when we are giving high dose low molecular weight heparin? We are heparinizing them. What is the disadvantage of giving tenecteplase to cell cases followed by IV heparin?
100%. That's excellent. So it has been tried, and we are now giving tenecteplase to many patients of acute heart attack or acute MI, acute stroke, and acute pulmonary embolism as the first measure in this COVID era, whether they are suffering from COVID or not. The first treatment is thrombolytic therapy using tenecteplase or TPA. So, and it is found to be very effective, and also it gives us time to react to the patient by taking them a little later to the cath lab rather than rushing them to the cath lab by, and then at that time exposing everybody to an unknown situation where we don't know whether the patient is COVID positive or not. And about 10% times these patients actually turn out to be positive. So this is being used, and it is very effective. And I must say that all the units are actually using it whenever required.
So from MI, I come back to again corona infection, जहाँ पे एक happy hypoxia हो रहा है. Oxygen level 60 है. You know that a patient is not mentally alert, which is happy hypoxia. We know that वो तभी होगा जब इंटरनल लंग में शंट होगा, कार्बन डाइऑक्साइड रिलीज हो रही है, यानी कि ब्लड में जा रही है, लेकिन ऑक्सीजन की कमी है. दैट मीन्स लंग्स के अंदर में कहीं ना कहीं पे एंजियोनियोजेनेसिस है, क्लॉट फॉर्मेशन है. So why can't hospitals like you come out with a study as a blind study to see that in every case of happy hypoxia, we treat them as microembolism, we treat them as macroembolism. The same patient, अगर आप macroembolism का होता तो आप immediately उसको thrombolize करते. Why can't we thrombolize all the patients of happy hypoxia and then give them a IV heparin? Because if you give them IV heparin without dissolving the clot, I mean, we used to give them thrombolysis in DVT for 4 days, 5 days, 6 days, 1 lakh per hour till the clots disappear. But here the condition is acute. It's not a chronic DVT. It's a, because we know that happy hypoxia comes on day 3, day 4, day 5. In such cases, why hospitals are not thinking of giving tenecteplase?
I think so. I don't have any definitive information on this, but I think because there are two ways hypoxia happens in a patient of COVID infection. One is because of the pneumonitis or the interstitial pneumonia, the ground glassing which happens in the lungs, and the second is pulmonary embolism. So those patients who have a definitive pulmonary embolism, which is proven by echo or by a CT angiogram when it is done, then in these patients giving thrombolysis will definitely lead to substantial benefits. But in those patients where the main hypoxia is because of pneumonitis or because of ground glassing, one of the side effects which can happen is that they can have interstitial bleeding, and that can lead to flooding of these lung cells and might deteriorate the condition. So that is why I think we'll still have to prove that yes, thrombus formation has happened and thrombus is obstructing the arteries in a big way.
Microthrombus में तो दिखेगा ही नहीं, coronary
Yeah,
pulmonary
but the thing is,
I know. Therefore, I'm only talking today of lateral thinking. I have not to my viewers. This program is not supported by any pharma. We are not influenced by any pharma. And in COVID-19, we make sure that we go for a lateral independent thinking. And we are only discussing out of box today, so that maybe somebody starts a program, goes right to DCGI and ICMR, and cites a program. We are only trying to find out it because IMA has assigned me a job how to reduce the mortality. I'm only working on finding ways to reduce the mortality, because I particularly feel in my mind is that there are microthrombi which needs to be taken. And up till now, I have my experience is if you start oral anticoagulation early, it prevents even formation of happy hypoxia in these cases. But I don't know, unless the evidence comes, unless the Ministry of Health guidelines or ICMR guidelines comes, till that period, it will remain as anecdotal observation studies of the people. Coming back to as on today, what is the scenario? We have heard that your hospital has taken over as a cardiology department of Mulchand Hospital. And now you are in Delhi at one in Medanta. Now you are also present in Delhi. So how at the moment, how comfortable patient should feel of going for an interventional procedure in the COVID era?
Okay. So, Dr. KK, I think these are very important. The very important question: how comfortable a person should feel, and this is a very, very common question which people come with every single day. Even today, I was doing a OPD in the morning at Murchand Hospital, and the patient was asking whether it is safe to come to the hospital. I don't want to come to the hospital. Everybody is saying the same thing. So this is very important point you have raised, but I must reiterate again that now we have geared up. Everybody has learned the tricks that how to remain, sterile areas separate, how not to mix up patients. So I must give this message to everybody that coming to a hospital is no major risk at all. You are more at risk when you go out in the market, you go out to meet anybody, but in the hospital generally people are more kind of covered up. They are the masking is much better, and the areas are very sterilized. So please do not hesitate to come to the hospitals, because sometimes you can do more harm by not coming to the hospital than coming to the hospital. So that kind of fear should go away from people's mind, that it is risky to go to the hospital.
Coming back to from emergency to planned surgeries, planned procedures. I'm talking about where you have to go for, suppose TAVI. Suppose we have to replace a valve at this particular moment. How comfortable the cardiology department is, whether at Mulchand or in your own hospital or anywhere, any other Medanta hospital, anywhere in the world. At this moment, I'm talking about planned procedure. Are we opening up?
So again, I must say that this is a very interesting point again, and we thought about it, and now I can say that it is in fact better to go for planned procedures at this point in time, because the sterilization levels are very high. The availability of doctors, technicians, the nurses is very high, because nobody is going on leave these days. So we are available all the time. Patients are being taken care of, and in fact, I was thinking, it is just between you and me. I was thinking, if it was a COVID era all the time, the patients will get a better care, because we have
Absolutely, the
more time
mortality
for
is low.
patients.
Yes, you have more time. You have no time for holiday. You have no time for
Yeah,
conferences. All conferences now
absolutely.
are on the virtual level. Yes,
Yeah.
I agree with you. I absolutely agree with you. Therefore, I want to give this message to the community that have faith in your doctor and go back. If you are in doubt, get your COVID test once or twice. If you do, all the guidelines says if your COVID test twice is negative, practically you are negative. And if you are still want to be sure, get your COVID test, all of your relations. If you have 6 relations and house, get all of them tested. If everybody is negative, you know that you are negative. I mean, these are the policies for the government to decide. But yes, definitely आज की डेट में डरो नहीं, अगर जरूरत है तो जाओ, अपना इलाज कराओ, डॉक्टर्स आपकी केयर कर रहे हैं, and the risk is very 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 low. आज 6 महीने के बाद में हम ये नहीं कह सकते कि अननोन वायरस है. नो, हम ये नहीं कह सकते हमें इस वायरस के बारे में नहीं पता. It's 6 months. The government has given a 6 months diploma to every public. कैसे अवॉइड करें, कैसे बचाएं. सब लोगों ने 6 महीने का अपना कोर्स कर लिया है कि मैं बीमारी को कैसे बचाऊं, और वैसे ही 6 महीने का डिप्लोमा हर डॉक्टर ने कर लिया है कि मैं कैसे अपने को बचाऊं और आपको बचाऊं. दोनों इंपॉर्टेंट है. सो आई थिंक टाइम टू ओपन अप. फॉरगेट अबाउट दिस राइजिंग नंबर. नो, वो बढ़ेगा. वो आज की डेट में बढ़ रहा है आपकी अपनी गलती से, वो किसी की गलती से नहीं है. बिकॉज अगर आप अपने आप को नहीं बचाओगे तो डेफिनेटली आपको बीमारी होने के चांसेस ज्यादा होते हैं. बट मोर्टैलिटी रिडक्शन नाउ इज सब्सटेंशियल. मोर्टैलिटी रिडक्शन इज नाउ सब्सटेंशियल. आई थिंक ज्यादा एमआई पकड़ में आ रहे होंगे. अब लोग जल्दी अस्पताल में एमआई, ज्यादा बीमारियां पकड़ में आएंगी और अच्छा ट्रीटमेंट आपको मिलेगा. और एक और चीज है प्रवीण जी, कि ये जो लोगों ने आइसोलेशन सीख लिया है और क्वारंटाइन सीख लिया है, आई थिंक द टाइम हैज कम फॉर ऑल ऑफ अस टू इवन टेल आवर पेशेंट्स, मीजल्स है, चिकन पॉक्स है, आपको हर्पीज ज़ॉस्टर है, आपको टीबी है, ओपन आइसोलेशन कर लो. अब आदमी खुशी से करेंगे, पहले कोई नहीं करता था. पहले
Absolutely.
टीबी वाला आदमी घूमता रहता था. अब टीबी वाला आदमी को पता लग गया है कि ये बिल्कुल भयानक बीमारी हो सकती है, तो मेरे ख्याल से एमडीआर टीबी भी हमारी कंट्री से खत्म होने के चांसेस पे आ जाएगी।
करेक्ट, करेक्ट।
So anything else you want to say about your experience in the last 6 months? डर तो नहीं लगा आपको कभी पर्सनल एक्सपीरियंस में, कभी ऐसे मन में डर तो नहीं लगा? पर्सनल डर जी, घर के अंदर में
इनिशियली थोड़ा बहुत सोच रहे थे हम लोग, बट डर तो कभी नहीं लगा, बिकॉज वी हैव बीन डीलिंग विद दीज काइंड ऑफ प्रॉब्लम्स डे इन एंड डे आउट, ऑल्दो इन जस्ट द हॉस्पिटल एटमॉस्फेयर, बट नाउ इट इज ऑल इन द पब्लिक। लेकिन सबसे बड़ी चीज़ है कि कोरोना ने हम लोगों को, जैसा कि आपने बताया, कि बहुत कुछ सिखा दिया, और ज़िंदगी में किस तरह से हमें किसी प्रॉब्लम से लड़ना है, कैसे उससे तुरंत अपने आप को अडेप्ट करना है। सो दैट अडेप्टेबिलिटी ऑफ ह्यूमन रेस हैज़ रियली शोन in a very positive direction to everybody, and we have adapted. We are going to adapt more, and life will come back to normal. So people have to just, stay cool, stay, safe, take precautions, and if they do all this, I think we are going to really succeed in the next few months.
और वैसे भी WHO ने आज कहा है कि पेंडेमिक तो आते रहेंगे। अब आके दिखाएं, we will be better prepared, because now गवर्नमेंट ऑफ इंडिया has also said कि MBBS के अंदर में पेंडेमिक के ऊपर में स्पेशल टीचिंग होगी, यानी कि it will be a special subject as far as pandemic is concerned. So forget about the mortality, try to live normal, but with a prevention. Remember the three things: masking, physical distancing, and hand hygiene are important. This masking will help you in reducing respiratory illnesses. Forget about only corona. Hand hygiene will take care of all food and waterborne diseases. These two hygiene will be able to help you in reducing and improving the hygienic status of the society and of the country. Maybe you will stop seeing typhoid, diarrhea, and other diseases. That's all for today. Let me thank Dr. Praveen Chandra and wish him luck for his new venture in Delhi, and wish Medansa also a good luck, because a hospital where I worked for almost 4 decades, which now Dr. Praveen Chandra is joining. I hope they would have continued at the time when I was there at that particular moment. They came for a short period and they left. So thank you very much, Dr. Praveen Chandra, to be here, and all my viewers, thank you very much. We'll be back tomorrow, 7 p.m. with another show. Stay tuned. Namaskar.
Thank you.